So when a patient comes to our center, the citizenship is something we document. However, we have to treat the patient. That's part of our responsibility. When a potential patient is accepted into our program, UNOS recently, about 6 years ago, changed their guidelines to where there is no minimum or maximum number of patients that you can transplant from another country. What's critical is that you meet the criteria, because you have to remember, transplant is not a cure. It's a therapy that allows that organ, this new organ, to function, but continuous healthcare follow-up is needed at the transplant center. So when we look at an international patient, we want to make sure they can be a good steward of that organ. And when they return back to their normal lifestyle, can they get the therapies that they need in their home country is very important. And then how can they come back to our center when they need critical therapy that's involving the transplant? So we look at the whole process, not just the transplant itself. The short wait times are obviously very critical. The more illness the patient develops because of their disease, the more debilitated they get, that makes it more challenging for their recovery. So the quicker we can get them transplanted, obviously is a benefit to the patient. However, we see all patients. Many times patients are referred to us from other centers after they've been waiting for a long time, and then we get them transplanted. So they may have been waiting at other centers, and then they're referred here. So we have to take that into consideration. Overall, I really accredit that because we are a transplant institute and our heart, lung, liver, kidney physicians, surgeons, nurses, social workers, dietitian, we're all housed in one building. And the intercollegial conversations that go on in our clinic, in our discussions when we select patients, because we're all living in the same house, we have better connection. And I think we, again, treat the patient more holistically at our center. Not all transplant programs have that ability when you're dealing with advanced organ failures to have all the doctors and healthcare team together in one location. And I think that's a big attribute for our center. I do. Our kidney transplant program, average length of stay, we strive for 4 days, 3 days if it's a living donor. We try to get our living donors out of the hospital, the actual donors, within 24 to 48 hours. Our liver transplant program is usually 8 to 10 days. Our heart transplant program is usually 8 to 10 days. And our lung transplant program is about 10 to 12 days. What's also critical for us at our Transplant Institute is we have what's known as our Barch Transplant House, and it's a special hotel for our patients. We have 24 rooms, so if you're from outside the Orlando area, even though we discharge you early, your medical home is still there, but it's on an outpatient basis. So because we have this hotel on our campus, we can see our patients earlier and we can discharge them earlier. And actually the best place for a transplant patient after their transplant and after the emergent care is for them not to be in the hospital. We want them up and walking and running and rehabilitating as fast as we can. Organ transplantation really started in the 70s and 80s, thanks to Dr. Starzl, Dr. Najarian. And back then, when I was practicing in the field, we basically had 3 immunosuppressive drugs. And if you failed on those 3 immunosuppressive drugs, we had one drug that was really super powerful. Today, our inventory of medication that we can utilize is very specific in identifying where's that rejection coming from, and we can very quickly detect that rejection. I wish we had a better word than rejection because it sounds so bad, but we see it at the very early cellular level. And we have very specific medications that can target that today. The second piece is that we're smarter today. We can evaluate ahead of time to say, we know certain patients genetic makeup, HLA tissue typing, would reject if they received an organ with those specific genetic markers. So we identify that, and we can either try to eliminate those genetic markers, so we suppress it and then treat them with the right immunosuppression and monitor them. So we're very targeted now compared to where we were back in the 70s and 80s. The other piece is we've gotten smarter about our organ selection, and we understand what organs are better for certain patients and how we could better select and design that. Obviously, for kidneys, living donor is the best organ that can be available. It's the shortest amount of cold time, and usually it's the most controlled scenario that we can do in transplantation. Obviously, it's always a balance between keeping rejection and keeping infection in check. And we have many physicians, and especially our infection control doctors, work very closely with our transplant surgeons and our transplant physicians today. We've grown up, we've taught, initially it was our transplant surgeons that were critical care and infectious disease and laboratory specialists. And now we've created all these professions within cardiology, hepatology, nephrology, infectious disease that are specialists in transplantation. So we have a whole team of doctors now that can really care for this patient. Also, the hospital itself, having designated transplant units where the nurses, the social workers, the therapists are all specially trained, and we follow a protocol, and we really do adhere to that protocol. So that the patients all get the same therapy, the same treatment. And when we deviate for a very good reason. And it's done in a team manner. It's not done in a very siloed fashion. So far as designer 3D printed, I believe we're still a little bit off. We have physicians that have been very smart in growing organs across the world. However, I don't believe we're quite there yet. I think a therapy we may see reemerge is xenotransplantation, and that's using animal organs. There's quite a few centers that are still looking at xenotransplant as an option. I know there's work at the previous center I was at where we were using pigs, genetically cloned pigs, to look at for treatments for diabetes, to end diabetes and be able to take islet cells from a pig and transplant them into a human. And we've had great success with that. So I believe there's other options out there. But at the end of the day, it still requires organ donation, and that's the limiting factor in transplantation. For a practicing physician to be able to have to tell a family or a patient that 20% are going to still die waiting on the wait list is very hard to do when we know once we get that organ, we have a very good chance of helping that patient survive. I'm very hopeful for that. Again, we have so much technology today. We have so many bright physicians and scientists worldwide. I truly believe this within the next 10, 20 years, we're becoming so much smarter. There's many ways of doing non-invasive therapies today based off of just looking at the blood and predicting if there's rejection, if there's infection, and detecting it early and treating it with the right medication or gene or whatever we'll have in the future to turn on and turn off the regulators that are causing that inflammation or infection.